Let's talk about obesity in pregnancy. Obesity is classified into three categories. BMI of 30 is class 1, BMI of 35 is class 2, and 40 is class 3. 40% of pregnant women is obese. Effects of pregnancy, uh, pregnancy loss, we have spontaneous abortions and recurrent miscarriages due to obesity. There's increased risk for uh, 2 times uh, increased risk for neural tube defects. Actually, we'll just take a look at this table here. So neural tube defects, about 80% increase. Spinal bifida, 2 times increase. Um, Cardiovascular, 1.3 times. Septal anomaly, 20%. Cleft palate, 20%. Anal rectal atresia, 40%. Hydrocephaly, 60%. Limb reduction, 30%. So the big ones is spinal bifida neural tube defects and cleft palates, limb defects, and cardiovascular. So there's a slight decrease in gastroschisis apparently. Antepartum complications. There's increased risk for this maternal cardiac dysfunction, proteinuria, sleep apnea, non-alcoholic fatty liver disease, GDMA, preeclampsia. The risk of stillbirth is 2 times greater for someone with BMI of 40. So let's see, risk of stillbirth. Um, Someone who has a BMI of 20, the risk of stillbirth is 4 in 1,000, so 0.4%, right? If the BMI is 25, it's almost 0.5%. If it's 30, it's 0.6%. I guess if it's 40, then it's 0.8% almost. Intrapartum complications, increased risk for C-section, 2 times the risk for BMI of 30, failed trial of labor, endometritis, wound rupture, VTE. Class 3, increased risk for atonic hemorrhage after a vaginal delivery, but not a C-section. Risk for failed epidural, and they also have greater risk for hypotension and prolonged uh, fetal heart tracing D cells after an epidural. Postpartum complications, weight retention, risk of postpartum hemorrhage, again after the vaginal deliveries, early termination of breastfeeding, anemia, depression, behavior counseling intervention, fetal complications and childhood morbidities, patients fetal macrosomia, impaired growth, childhood obesity and asthma. When can we see improved perinatal outcomes? If the patient loses weight prior to pregnancy, even a 5% weight loss can help. Metformin starting at 10 to 20 weeks without diabetes did not improve outcome. Recommendations for weight gain. So if you're normal weight, usually recommend gaining 30 pounds during pregnancy. Daily protein intake should be around, let's just do around 1 milligram per kilo. Daily carbs 130 gram to 170 gram per day. First trimester, no additional calories required. Second trimester, 350 extra, and then third trimester, 450 extra. So this is for normal weight pregnancies. So if you're overweight, 15 to 25 pounds weight gain. If you're obese, 10 to 20%, 10 to 20 pounds weight gain. No weight gain or weight loss can lead to small gestational age, lower detection for anomalies. Obese patients have lower detection rate for anomalies due to increased risk for stillbirth. We recommend if you are BMI 30 plus, weekly NST at 37 weeks. If your BMI is 40, weekly NST at 34 weeks. These patients have longer labor course and increased risk for prolonged pregnancy and rate of labor induction. I feel like these should be intrapartum, huh? Intrapartum complications. Put it here. Patients undergoing VBAC in class 3 obesity. VBAC patients in class 3 obesity can have an increased risk for prolonged hospital stay, endometritis, rupture or dehiscence. They also have increased neonatal morbidity, including fractures, brachial plexus injury, and lacerations, although absolute risk is small. Antibiotics for these women, if we're getting a C-section, we should give cefazolin 2 grams. If you're 80 kilo, if you're over 120 kilo, you should get 3 grams. 120 kilo is around 220 pounds. Vaginal cleansing for laboring patients or rupture membrane patients. Well, actually nowadays we recommend azithromycin for all laboring patients or ruptured patients who's getting a C-section. Azithro and cefazolin. Metabolic disorders of pregnancy, screen for OSA and glucose intolerance. OSA patients have increased risk for preeclampsia, eclampsia, cardiomyopathy, PE, and also in hospital mortality, postpartum care, weight-based postpartum heparin dose if BMI is greater than 35, less than 100 kilo. Let's see, less than 100 kilo is 100 kilo in pounds. Okay, so 220. Oh, this is 260. This is 280. 180 pounds. Okay, so weight-based, less than 100 kilo, which is 220 pounds. We can give Lovenox daily or unfractionated heparin 5,000 units Q12. If they're greater than 100 kilo, Lovenox 600 daily or heparin 5,000 units Q8. Let's see, so or we can use DVT prophylaxis 12 hours after C-section using a weight-based 0.5 milligram per kilo enoxaparin every 12 hours dose. So the anti-XA concentration was significantly higher in the weight-based group. So weight-based dosage can be considered rather than the BMI stratified dosage. So 0.5 milligrams per kilo every 12 hours. Zero 0.5 milligrams per kilo enoxaparin Q 12 hours. And this is 12 hours after C-section. So if you are, let's see, 100 kilos, that will be 0.5 times 100 kilo. Okay, so 50. So 50, 50 Q12 versus 40 daily. I mean, that's like a lot more. Bariatric surgery, Roux-en-Y, restrictive and malabsorptive effects. Gastric banding is just restrictive. Should not be considered uh, infertility treatment. Need additional contraception if on OCP. Increased pre-prom compared to general population. Prior bariatric surgery is not associated with perinatal death. We should wait 12 to 24 months before conceiving. Higher dose of folate show no decreased risk for birth defects. Patients still need 60 grams of protein daily when pregnant. Need to take prenatal vitamin on top of normal vitamin supplements. Care with vitamin A, it should be less than 5,000 international units daily. Delay in diagnosis of complications, anastomotic leak, bowel obstruction, internal hernia, ventral hernia, band erosion or migration. There could be dumping syndrome. Patient might not tolerate 50 grams of glucose test. 1 week home glucose monitoring around 24 to 28 weeks can be the alternative method. Extended release medication is not recommended. Independent risk for C-section. And other nutritional information. So 1 gram of total iron needed for the whole pregnancy. This is just in general, I guess. Vitamin D deficiency, serum 25 OH, vitamin D, less than 32 nanograms per milliliter, up to 4,000 international units a day during pregnancy is safe for vitamin D.